Right. Hi, everyone. Sorry about that. Um, just had some technical difficulties there. Hopefully, everything is good now. Um, good evening. My name is Aylah Clark, and I'm a naturopathic doctor at Whole Health Wellness Center. And tonight I'm going to be talking about cholesterol and 9 ways to better understand cardiovascular risk and some evidence based natural treatments to reduce those risks. More specifically, I'm going to do a little overview of just the basic lipid panel or cholesterol panel. I'm going to go through those 9 different markers that can give us a better idea of risk. For each of those, I'll be talking a little bit about evidence-based natural treatments. And then the second part of the talk is on modern nutrition for cardiac risk reduction, specifically some of our more recent research on dietary cholesterol, fats, especially saturated fat, ultra processed food, and sugar. So I'm very excited for you to hear all of this stuff, especially that second half. And the first part will really be helpful for understanding some of what I talk about then. So let's move on. So first, the basics. What is cholesterol? You can see cholesterol pictured here in its molecular form. It is technically a steroid because of its shape. Those hexagons and pentagon shape make it a steroid. And that actually does create some of the backbone substrate we need for hormones. Currently, the American College of Cardiology and the American Heart Association guidelines want total cholesterol under 200. LDL is often called your bad cholesterol. You want that under 100. 100 to 130 is considered borderline. And in some high risk cases, we want that under 70. The HDL is often called your good cholesterol. For men, we are looking to have that over 40, and for women, over 50. Triglycerides are closely related to sugar intake and alcohol. We want those under 150. And you'll also usually see your total cholesterol to HDL ratio on your lab report that you want under 5. All right. So why do we need to know more than this? We've been using this for quite some time. Well, if we think about it, so the goal is to lower risk. The whole point of testing cholesterol and trying to lower it to these ranges is to reduce cardiovascular risk. Currently, the way we do that is primarily with statins, and that focus is on lowering specifically LDL primarily. The problems with this is that the basic panel isn't the best way to predict risk or judge treatment efficacy, that's the whole point of this, is really that is not the best way for us to understand risk, and it's not the best way to know if we're doing what we need to reduce that risk. LDL is an incomplete indicator of cardiac risk. Some examples of that that show that are that many trials where LDL is lowered to these ranges still result in cardiac events because they don't completely lower all of that risk. And many people that have coronary artery disease, which is coronary arteries surround your heart, many people actually still have normal LDL, but they can have coronary artery disease for other reasons. Also, many people can't take statins, and importantly, we just now have more information. We can now tailor prevention strategies more effectively. So let me go into more detail about these numbers, and you'll understand what I'm talking about. So the first of these 9 markers I want to talk about is the LDL particle number. The LDL particle number is looking at the particles in the serum. So particles actually hold cholesterol. We're measuring the LDL-C or the LDL cholesterol already that's located inside these particles. But if we actually look at the LDL particle number, it's more predictive than LDL and other markers like non-HDL for cardiovascular risk. An elevated LDL particle number can be associated with about 1.4 times the cardiovascular risk, according to the Framingham Offspring study. Now, in cardiovascular research, you'll hear the name Framingham a lot. This is one of the sort of gold standard longitudinal long-term research studies that we get a lot of data from. It's been going on long enough that we're now in the offspring study, so we're to the next generation. And so this next slide is going to illustrate LDL particle number and risk a little bit more. So I promise the whole talk is not going to be this technical, but I am going to walk you through this chart because it's very interesting. So this is using data from the Framingham Offspring study. And what they did was they divided the participants into 4 groups by high and low LDL particle number and high and low LDL cholesterol number. So if you did a matrix of those things, you would end up with 4 groups. And so as this whole chart in general is looking at the probability of not having a cardiac event. So over time, as years go by, that probability of not having a cardiac event goes down for everybody. So your risk goes up. The further to the bottom right of this graph that you get, the higher likelihood of having your risk of a cardiac event goes up. So you want to be in those top 2 lines. Those are a lower risk. And what those 2 lines have in common is they both have an LDL, a low LDL particle number. And so interestingly, low versus high LDL cholesterol number does not predict this outcome. You can have low LDL cholesterol and be in either range. What matters is whether or not your LDL particle number was low. So that's just a way of illustrating that the LDL particle number is more predictive than LDL cholesterol at predicting a cardiac event. All right, so I hope you guys hung with me through that. So some treatment approaches I want to mention here is just things that can lower LDL particle number can include decreasing inflammation, omega-3s, niacin, a low carb, especially low sugar diet, and actually higher fat. So we'll talk about the fat, of course, later. And as I go through these treatment options, I know I say this in all my talks, but not everybody needs to be doing all those things. That's really good to figure out with your doctor. All right, number 2. Number 2 is your LDL particle size. So those particles that I was talking about in the last slide can come in different sizes. You can have small, dense particles ranging up to big, fluffy particles. You want more big, fluffy particles. That's associated with lower cardiac risk. Pattern B is when you have a lot more small, dense particles. That's associated with higher risk and tends to happen more in adult men. 30 to 35% of adult men have pattern B. And that can also be associated with insulin resistance. The studies have shown that LDL particle size was the strongest predictive factor for the presence of coronary artery disease when compared to LDL, triglycerides, and HDL. There have been several recent studies that have shown that small, dense LDL is associated with coronary artery disease independent of other variables like having low HDL and high triglycerides. So it's not just that people that have small, dense LDL also tend to have other issues with their cholesterol panel. It is independent of those. Other studies aimed more at treatments have shown that what would make sense with given all this, that if you also improve particle size and not just lower LDL, then you have improved clinical outcomes and reduced mortality. Importantly, statins have little effect on particle size in people that have pattern B. So even though the statin can be very effective at lowering LDL cholesterol, it doesn't improve particle size, or it doesn't for most people with pattern B. Some things that can improve particle size are some classics, the Mediterranean diet, omega-3s, as well as some other interventions like niacin, bergamot, aerobic exercise, healthy fats like olive oil and nuts, green tea, alternate day fasting, and avoiding trans fats. A third marker I like to look at has to do with HDL dysfunction. So to understand this, we need to go back to understanding HDL. So again, this is our good cholesterol. HDL is good because it acts like a dump truck. It goes around your vasculature and helps remove excess cholesterol, brings it to your gallbladder, and ultimately it gets removed from your body. So when HDL is functioning well, it is anti-inflammatory, it's an antioxidant, it's helping reduce plaquing in your arteries, and that's why a high HDL is associated with lower cardiac risk. Unfortunately, we're finding that in certain situations, HDL can become dysfunctional. Inflammation, infection, and diabetes are a few of those things that can make HDL not work as well. That decreases its ability to remove cholesterol from your body, and therefore that's called the decreased cholesterol efflux capacity. And not only is that just not as good, it actually becomes more pro-inflammatory and it can increase plaquing in the arteries. So the point here is we need quality over quantity when it comes to HDL. Just because your HDL is high doesn't mean it's working well. And this has been shown in several studies as far as, can we just improve HDL and see an improvement in these numbers? And in most large-scale clinical trials, when we use treatments to raise HDL, it doesn't necessarily improve cardiac outcomes. Same thing if you have a genetic variation that results in high HDL, it actually doesn't necessarily decrease the risk of a heart attack because you're not necessarily increasing the functionality of the HDL. So let's talk about this a little more. So HDL dysfunction, quantifying that is actually not just one test. There are different ways that we can look at HDL dysfunction. Some of these are more readily available than others. Cholesterol efflux capacity is probably the best, but it's a little less easy to come by. Some of the others are easier, and you can also get some good information from them. For example, you can do a test called HDL MAP that looks at different forms of HDL, like alpha-1. The Framingham offspring study showed that alpha-1 HDL particles had a stronger association with heart disease prevalence than either HDL cholesterol or LDL cholesterol. I'm not going to go through all these bullets, but maybe I'll talk about the next one. So similarly, every 1 point increase in HDL decreases the odds of heart disease by 2%. But for every 1 point increase in alpha-1 HDL particles, actually decreases the odds of heart disease by 26%. So it's definitely important to have the alpha-1 particles, and that's not really what we've been looking for. And another important note is that statins don't tend to affect this. There are some studies that have indicated it could actually decrease cholesterol efflux capacity. This isn't an anti-statin talk. There are great reasons for certain people to be on statins, and I will mention some of the ways that they can do well, but I think it's important to know that they don't lower all your risks. So certain treatment approaches that can help reduce or improve HDL functionality include flavonoids, which can come from plants, eating plants, vitamin E, quercetin, pomegranate, lycopene, omega-3s, and niacin. Okay, ApoB. ApoB is short for apolipoprotein B100, and it is the main protein in plaque-forming particles, including LDL. So you're familiar with LDL. We also have IDL, VLDL, lipoprotein little a. And so all of these form plaques. Each of them has a single molecule of ApoB in them. So by counting ApoB, we can often get a better look at plaque forming potential in your body. So I'm going to read this quote from a 2006 article in the Journal of Internal Medicine that illustrates its importance well. So, evidence from fundamental epidemiological and clinical trials studies indicate that ApoB is superior to any of the cholesterol indices to recognize those at increased risk of vascular disease and to judge the adequacy of lipid lowering therapy. On the basis of this evidence, we believe that ApoB should be included in all guidelines as an indicator of cardiovascular risk. So ApoB is a great one to have in your hip pocket and to include to assess cardiac risk. Some treatment approaches that can help improve ApoB numbers are exercise, flavonoids again, like quercetin and naringenin, omega-3s, weight loss, smoking cessation, reducing any added sugars, increasing fermented dairy, and statins can improve ApoB. All right, so one of those that we talked about briefly was lipoprotein little a. So that was one of those plaque-forming particles on the last slide. We can also look at lipoprotein A specifically, and it is sometimes called LP little a, or lipoprotein little a, and it is an independent risk factor for coronary heart disease, peripheral artery disease, aortic valve stenosis, and heart attacks. And most of what causes lipoprotein little a to elevate is genetic. That's 80 to 90% of it. And 10 to 20% of the population has a high lipoprotein little a. So because it's genetically determined, it's a little bit more challenging to lower lipoprotein little a, but it is possible. From the natural standpoint, monounsaturated fats like olive oil, avocado, and nuts seem mostly to decrease lipoprotein little a in studies. Niacin has some potential there. There are some studies where it was lowering it by 20 to 30%, but that's probably not true for everybody. And L-carnitine is another potential. Statins may actually increase lipoprotein little a. So that's just good to have in mind when looking at the whole picture. There are some new drugs that are coming out that can pretty effectively lower lipoprotein little a. Just to have on the radar that things are kind of evolving there to help in other ways. Okay, number 6, CRP. If you came to my inflammation talk last month, then you have heard of this one before for sure. So hsCRP is our primary marker of inflammation. It is another independent risk factor for cardiac risk, even if inflammation is caused by something else. So if you have elevated CRP because you have an autoimmune condition, infectious diseases, obesity, smoking, periodontal disease, any number of reasons for that to be elevated, it can still increase your cardiac risk. So even in people who are otherwise healthy and don't have any evidence of plaquing in your arteries, elevated CRP is still important for heart health. This one, ideally, you have that less than 1. 1 to 3 is moderate risk, and greater than 3 is high risk. So I will be doing that talk again, but as a little brief overview of some ways to decrease CRP, weight loss if needed, especially visceral fat, anti-inflammatory diets, smoking cessation, good oral hygiene, identifying and treating sleep apnea, omega-7s, as well as omega-3s, and increasing vegetable intake. All right, we're on 7 of 9, so homocysteine. Elevated homocysteine is also a great cardiac risk marker, especially for coronary artery and aortic calcification and stroke. If you look at this diagram, you can see that homocysteine is written in orange, and in order to convert away from homocysteine, there are several B vitamins, B6, B12, and folate. And so having inadequate levels of these B vitamins can cause elevated homocysteine. You can also have elevated homocysteine for genetic reasons, where this can impact how things are converted, how well they're converted. In those cases, sometimes supplementation with these can improve that number even more. So we weren't totally sure, based on the evidence, whether doing that would actually reduce your cardiac risk. When you think about, like, it makes sense that you would, if you were able to lower homocysteine in some way, you would be able to lower risk, but that's not always that straightforward. So it wasn't until 2021, when a large study was performed, that showed that providing B vitamins like these and lowering homocysteine in that way does actually reduce your risk, primarily B6 and folate. All right. All right, number 8 is insulin resistance. So I'm going to have a few slides on this one because I need to tell you what insulin resistance is. So insulin is produced by your pancreas, and it helps your body use glucose. So when you eat food, insulin is then produced to help your body get it where it needs to go. And so insulin resistance occurs when the cells, like in your fat tissue, muscle, liver, they can't take up that glucose and use it effectively. Your blood sugar is elevated, and often your insulin can also go up to try to compensate and try to lower that blood sugar. There are lots of conditions associated with insulin resistance, like prediabetes, type 2 diabetes, PCOS, and more. And there are also both intrinsic and extrinsic ways you could have insulin resistance. With intrinsic insulin resistance, you might be more wired to have insulin resistance, like in PCOS. Extrinsic factors like diet and lifestyle can certainly make that worse. For many people, it is only the extrinsic reasons why they have insulin resistance, but you can certainly have a combination of those. So insulin resistance can affect every part of your body. I'm not going to go through all of these, but we know that it can affect your pancreas more, where you could have type 2 diabetes, where your pancreas is not producing insulin the way it should be. In the vasculature, I'm going to go over to that side in the vascular endothelial section. Insulin resistance can result in increased vascular wall inflammation and plaquing, and it can contribute to unstable plaques. So in those plaques, there can be something called the necrotic core, which makes those plaques unstable and more likely to create a thrombosis. So insulin resistance is important, and tests that can help determine insulin resistance, there's also a few that you could do with this. There is an insulin resistance score you can do that involves insulin and C-peptide, and there's a calculation developed by Stanford that can give us an idea. Oral glucose tolerance testing can sometimes be helpful. And we can also get an idea about insulin resistance looking at your triglycerides, triglycerides to HDL ratio, hemoglobin A1C, and fasting glucose. So even slight insulin resistance can increase your risk of heart attack, stroke, cardiovascular disease, and mortality. And it's not just about lowering the blood sugar, because that's not the whole story with insulin resistance. So, as an example, in type 2 diabetes, when you need insulin, you need to give yourself insulin to keep your blood sugar under control. You're not treating the insulin resistance when you do that. You still should do that. You should still use the insulin if you need it, but it's not addressing those complications that can happen because of insulin resistance. But we have other ways of improving insulin resistance that do result in improvements in those areas. Some examples are exercising, nutrition, like a low carb and low sugar diet, if that's appropriate for you. And as a natural a supplement, sometimes we use berberine. And in the medication realm, metformin is an example of something that actually does work with insulin resistance. And the final test I wanted to talk about is the coronary calcium score. The coronary calcium score is the only one on here that's not a blood test. The rest of these are actually fairly easy to order on a blood test. This one is still easy to order, but it's a CT scan. A CT scan is a series of x-rays, and this one is looking at plaque in your arteries around your heart, which are your coronary arteries. This has become a little more common in the past few years because in 2018, the American College of Cardiology and American Heart Association guidelines endorsed using the coronary calcium score as a tiebreaker for people that had borderline risk and were trying to decide if somebody should be on a statin. So there are certain groups of people this is more useful in, those borderline cases. Men over 40, women over 50 with moderate risk could benefit more than some people with this test, especially if you have a strong family history or just unclear risk. There are some downsides, though. There is some radiation, though you're not typically doing this test very often. Some people only need to do it once, so the radiation isn't that big of a deal. You can sometimes have incidental findings. For example, occasionally you do a coronary calcium score, and because of the location, you also see your lungs, and you could have a benign lung nodule that shows up on there that we need to make sure is benign. So that can happen occasionally. And importantly, you can sometimes see a misclassification of risk because you can have a score of 0 on the coronary calcium score that doesn't tell us the whole story because it can't detect every form of plaque. And another important note is that even aggressive statin therapy doesn't change the progression of a coronary calcium score, which is disappointing, but true. So some treatment approaches is to reduce inflammation, eat a Mediterranean diet, get calcium intake primarily through food. Now, this is kind of a twofold thing. So calcium, there are some studies that have shown that people who get higher calcium levels through their diet can have a better coronary calcium score. But you can get too much through a supplement. So if you're not getting it through diet, you do need to be careful about how much you're getting through a supplement. How much is too much can vary a little bit by person, especially if you have absorption issues. But that's a good conversation to have, especially if you are taking calcium supplements. Vitamin K2 is probably the most interesting thing here because vitamin K2 helps drive calcium to your bones and away from your arteries. K2 has some very fascinating studies on that as well. So I'm not going to go too much into that, but that's good to know. All right, congratulations, you've made it to the second half of my talk. Um, Now we're going to change gears and we're going to talk about some of our modern nutrition understanding for cardiac risk reduction. Okay, so to set the stage here, we need to know where cholesterol comes from. 80% of cholesterol is made in your liver. Only 20% actually comes from the food you eat. What you eat can influence cholesterol production in the liver. So, of course, what you eat still matters, but it's how we affect the liver's production of cholesterol that's most important. I also want to address dietary cholesterol right off the bat. Eggs have gotten a bad rap. It's confused people over the years because advice has gone every which way with this. But numerous studies have shown that consumption of dietary cholesterol, especially through eggs, has little to no impact on cardiovascular risk. And studies have shown there is no correlation between the highest intake of eggs versus the lowest in incidence of heart disease or stroke. And there is no increase in your total or LDL cholesterol. Part of this is because that exogenous cholesterol intake, so getting it from food, actually can downregulate your own body's production of cholesterol. So you can actually end up with similar levels of certain ratios. And I also, another thing that sometimes bothers me with people avoiding the yolks of eggs is that they are so nutrient dense. They have lutein, zeaxanthin, and choline that, especially that choline, it's an essential nutrient. You have to get it from your diet. Your body doesn't make it. And there aren't that many high food sources of choline. Eggs are one of the most common. In most Americans, 90% of American adults have inadequate choline intake. So if you take away those egg yolks, it's really limiting people's choline intake. So don't worry about eggs, is generally my approach. We also need to just address fats as a whole. So I have many patients that come in that are worried about eating fats in general because of their cholesterol. And fats overall can actually decrease your cholesterol and improve cardiac risk. Some of these won't come as a surprise to you guys. So avocados, there was a review of 19 clinical trials, 5 observational studies done that found that avocados lowered LDL triglycerides, those small dense LDL particles we talked about, and improved vascular endothelial function. There are lots of studies on nuts and seeds in lowering these numbers. Olive oil can actually enhance cholesterol efflux capacity, improving HDL functionality. We talked about that. And it can reduce plaquing, reduce inflammation. And so these fats are primarily polyunsaturated and monounsaturated fats. So what we really need to have a discussion about is saturated fats. So our current guidelines recommend limiting saturated fat intake to under 10% of calories. Recent studies are questioning this evidence and these recommendations, including the American College of Cardiology and the British Medical Journal. I'm going to read this statement from the Journal of the American College of Cardiology from 2020. The recommendation to limit dietary saturated fatty acid intake has persisted despite mounting evidence to the contrary. Most recent meta-analyses of randomized trials and observational studies found no beneficial effects of reducing saturated fatty acid intake on cardiovascular disease and total mortality, and instead found protective effects against stroke. So for many people, that comes as a surprise. We're going to talk about this in more detail to try to figure out, why this is and what the evidence has shown that has made them want to make these types of statements. So let's back up. What is saturated fat? If you look at this picture on the left, that top image, you'll see the string of C's, those are carbons, and you'll see H's connected to each of those carbons. Those H's are hydrogens. So the carbons are saturated with hydrogens. They are fully saturated. And so then if you look at the one below that, you see two hydrogens missing, and the carbons are then double bonded together. So that is unsaturated fats. So saturated fats are mainly found in things like meat, cheese, butter, cream, coconut oil, palm oil, cocoa butter. Now, saturated fats can increase LDL cholesterol. That's where these guidelines came from. So what are we missing? We need to go back to risk, not just LDL. So changes in LDL are not a marker of heart disease in and of itself. Just because LDL is lowered doesn't mean that risk is lowered if other parameters change. You remember our graph from before, our particle sizes, our HDL function, all those are important and more important in terms of risk than LDL. Replacing saturated fats with polyunsaturated fats has been associated with reduced cardiac risk, but that doesn't necessarily mean that saturated fats are bad. It does show polyunsaturated fats are good. And that seems to be the story over and over again. So another just interesting point is that there was a meta-analysis and systematic review done in 2017 of 8 randomized controlled trials and another one in 2014 that even showed that saturated fat intake didn't even appear to affect the basic cholesterol panels like LDL in certain populations, specifically overweight and obese individuals, which is a lot of people. So one reason for this is that saturated fats are diverse. We often talk about saturated fat as if it is one thing, but there are many different forms. And so some food sources of saturated fats may not pose any risk at all, and they may even be protective. They have different effects, and they shouldn't just be viewed in isolation because saturated fats can also be affected by the food matrix that they're in. All right, so this is another illustration of these shifting guidelines. This is again from the Journal of American College of Cardiology, showing the shift from our previous advice that recommended restricting saturated fatty acid intake to reduce the risk of cardiovascular disease. And in finding that a number of different foods that are relatively high in saturated fats, like whole fat dairy, unprocessed red meat, and dark chocolate, actually don't have any increased cardiovascular risk or diabetes risk associated with them. They're recommending new recommendations that should emphasize food-based strategies that translate better and really are able to encompass what truly reduces risk. All right, so I wanted to do a little more look at this because it's important to understand the risk and the studies involved. And because has been conflicting advice on saturated fat, a large review was done last year in 2021 that looked at several different studies, a number of different studies, and they found that those that had they did different studies that were like high fat versus low fat, high saturated fat versus low saturated fat, et cetera. And those that were high fat, high saturated fat, high polyunsaturated fat, all resulted in an increase in large LDL particles that we want and or decreased small dense LDL particles, and ultimately resulted in lower cardiac risk. In some studies, they noted there were people that were switching to a low-fat diet, and a third of those that switched to a low-fat diet actually went from pattern A, which is lower risk, the big fluffy particles, to a pattern B with higher small dense particles. So there's a caveat in this study. They found that people with pattern B, that at least some people with pattern B may see an increase in small dense LDL and a decrease in the large LDL with higher saturated fat consumption. And so this is important to keep an eye on, and this is a good reason to test. I like to test people before at the onset of whatever we do, and then if we make dietary changes or treatment changes, test later. Let's see how they're responding because people are different. Okay, so I'm going to go into talking about some other things related to nutrition now, and wanted to go through these common pitfalls in nutrition research. So one of the most common problems I see is not differentiating between ultra processed versus less processed foods, especially when it comes to meat. Not differentiating between grass fed versus grain fed, which introduces that omega-3 versus omega-6 effect. Ignoring the synergism of phytonutrients, vitamins, and fatty acids in a whole food, and the effects of decreasing one food type might be due to increasing another food type. See that's hard to avoid. Confounding biases, adherence, and relying on dietary recall are also very common. Okay, so processed foods, especially ultra processed foods, are associated with high risk of cardiovascular, coronary heart, and cerebrovascular diseases. So this is important to think about because if you are maybe moving more towards saturated fat intake because of that data from before, it needs to come from foods that are not ultra processed. Ultra processed foods are often high calorie, they can have added sugars, but they tend to be lower in certain vitamins, low in fiber. And there's some evidence that the processing itself can affect how we are able to absorb nutrients in our intestines. They often have many ingredients. And the part of the problem there is that the processing can actually create compounds like acrylamide and acrolein that have been associated with cardiovascular disease. Processed foods are often also in packaging that can transmit chemicals like BPA and phthalates that can increase cardiac risk. So ultra processed foods still need to be avoided. All right, so part of the reason that we have this sort of mixed messaging on nutrition is because of sugar's shady history. So for decades, nutrition research and on sugar and cholesterol was funded in a large part by the sugar industry. In the 1950s, we started to see some of the connections there between sugar and heart disease. So in the 1960s, the Sugar Research Foundation, which is now the Sugar Association, started sponsoring research to try to cast doubt on sugar's hazards and make it look like dietary fat and cholesterol was the real problem. And so by the 1980s, with that research coming out, our nutrition guidelines reflected that. Everybody heard eat low fat. It wasn't until 2016 that JAMA Internal Medicine published this explosive study exposing some internal documents about that history, including evidence that they had bribed scientists at Harvard to promote their views. So that's a little background. As another way of sort of reflecting this, we see that financial support from Coca-Cola, Pepsi, American Beverage Association, and the sugar industry in general will fund these research studies, and it is skewed. So they are 5 times as likely to find no association between sugar intake and obesity, which is crazy. It's not just the sugar industry that is a problem. The American Society for Nutrition and the Academy of Nutrition and Dietetics has a long history of partnering with the processed food industry and sugar industry with Kraft, McDonald's, Hershey's, Pepsi. And in 2018, there was a British Medical Journal article that talked about how the Academy of Nutrition and Dietetics did not entirely, their position papers did not entirely align with the science, and they tended to use an industry-friendly narrative. There's some really interesting articles on this, and this is not to say that this is true across the board with dietitians. There are other organizations that are really trying to get the bias out of what they do. So there's some definitely good people in those industries that are doing good things. So the truth has begun to emerge with our research that is not funded by the sugar industry. We're finding that sugar can make your liver create more cholesterol. It can lower your good cholesterol. It increases triglycerides, and a diet high in sugar has been associated with a threefold risk in death from cardiovascular disease. Last year, an article in Circulation concluded that cutting 20% of sugar from packaged foods and 40% from beverages could prevent 2.48 million cardiovascular disease events over the lifetime of the adult population and more conditions. Another article from 2016 that looked at across different studies on saturated fat and sugar intake basically concluded we need to shift these dietary guidelines away from reducing saturated fat, and we need to stop replacing that, especially with refined carbs and sugars. If we really want to reduce the burden of heart disease, guidelines should focus on reducing these sugars, especially sucrose, high fructose corn syrup, in the forms of ultra-processed foods and beverages. All right, so a little summary here of the nutrition takeaways is consuming dietary cholesterol from foods like eggs is not a major driver of blood levels of cholesterol. Polyunsaturated fats from olive oil, nuts and seeds, and avocado, wild-caught fish have well-established benefits for heart health. Saturated fat, story is not black and white, and it may actually be protective. There are different types of saturated fat. People respond differently to saturated fats, and that's where I do like to still incorporate that advanced lipid testing to get a better understand how an individual might respond to it. And when you are increasing saturated fat, especially from animal proteins, trying to get that from grass-fed meats and eggs to increase omega-3s and aim for less processed foods, less packaging, shop the perimeter of the grocery store. I like to ask, can you imagine the food growing? If you can't, sometimes that's further away from that whole food. Sometimes that means it's more processed. Avoid sugar and refined carbs. And overall, the dietary pattern is the thing that needs to be thought of and not just focusing on single nutrients. All right, so please pardon we're excited. All right, so that brings me to the end of my talk. Some final thoughts. Just knowledge is power. We have the ability to personalize treatments and to more effectively reduce risk. We should use them. Most of the tests I mentioned in the first half can be performed with very little out-of-pocket cost to most people. And we need to really look at the evidence with nutrition and continue, as we do at Whole Health, to just tailor that to the individual. And that way we can more effectively reduce your cardiac risk, which is what's really important. So if you're interested, of course, in scheduling an appointment or want to learn more about our practice, if you're new to us, please give us a call. I believe you'll have an opportunity to schedule something with the front office if you would like to at the conclusion here. So thanks for hanging with me. I hope you learned something, and I will be back in a month or two for a redo of that chronic inflammation talk. Have a good night.